day 2, and today we have two presentations related to challenges of managing COVID patients, and the second one is gastrointestinal manifestations of COVID-19. Please make sure that you fill in the pre-test before the presentation. So our first presenter today is Dr. Aysha Almas. Dr. Aysha Almas is a AKU BGME alumni. She is an associate professor and service line chief of internal medicine. She also served as program director of internal medicine for 5 years and did a number of innovations to improve the residency program. Currently, she is service line chief of internal medicine and has been very actively involved in COVID related all the initiatives in managing patients and making rota and everything. So Dr. Aysha is an MBBS of Dow Medical College. She has done residency from AKU and she has done PhD from University of Karolinska. Dr. Aysha, please, for the talk on challenges of managing COVID patients.
Assalamu alaikum, everybody. Thank you, Dr. Tariq and Dr. Natasha, for inviting me for the second session of COVID-19 seminar, which has been going on as a great course the last time and this time also. And my today's presentation is just going to be a bit of an update about what I showed in my last presentation, in which I showed a couple of numbers and some important challenges which we were facing. In today's talk, we will be moving on with some elaboration of our previous talk. So with this, I will start my talk, and I do not have any disclosure. So these are the objective of today's talk. So roughly, we will kind of evaluate the trend of COVID-19. You've been hearing a lot from the website of National Institute of Health Pakistan that the numbers are going down. And I would like to show what has been going in our hospital to the number of patients presenting with COVID. We will also briefly touch upon how the healthcare staff is doing on COVID infection. And more or less, most of the challenges are still there, which we had last time. But there are some new things that have changed while managing COVID patients, and also, other strategic and logistic things that have come up in this past 2 months. So the data that I'll be presenting today is roughly going to be till mid of August. So till mid of August, we saw around 1,134 COVID patients in all. And I presume that this number must have touched up to approximately 1,400 by now. So this is the daily trend of admissions that you see here, and I also show more or less the same slide in my previous presentation. Now here you see from February 26th, when we had our first case, and there is a gradual rise, and you see a lot of patients. So these are basically the daily new cases of COVID-19 that we were having. These are not the prevalent cases. So for example, you see on this date of 22nd of June, where we had 19 new patients admitted. And then as we move on to July, the numbers did come down. And then they have come down by like 31st of July. So numbers have come down, but we are still getting patients, not as much as we used to before, but they are still patients that we are seeing. And the point to emphasize this more is that it seems when you look at the general public, you feel that COVID has gone. So COVID has not gone as yet. It is still there in the community, and we still need to take care precautions. So just when the ban was lifted, everybody rushed to Naran and Kagan. And I've just finished a round today, and there was a patient who just came back from Naran and has turned COVID positive. So just to emphasize that although the numbers are going down, we still need to follow all the procedure of precautions. This is the trend of the total number of admissions and also acuity wise. So if you see the yellow line here, in February we had 3, and then in March we had overall 100 patients, moving on to a peak of 350 patients in June. and numbers did come down to 278 in July, and to mid of August, the numbers were down to 238. Admitted into ICU, in the special care unit, or in the wards. So in our hospital, we have three levels of equity in which the ICU provides the highest critical care, which has invasive ventilation, non-invasive ventilation, has CRRT. Our special care units are kind of a high dependency unit. They do not have invasive ventilation, but people are managed with inotropic agents in these wards. And the ward are the general care, where patients are generally kept at 4 liters of oxygen. Also, the equity is also based on the number of doctors and nurses that take care of these patients. So here you see that the number of critical patients has kind of remained more or less the same in the ICUs. However, the number of special care patients did peak significantly in June and has come down to 105 in July. And just to kind of give you an idea that what did we think of when we saw a peak from 178 to 232, what did AQ do at this point? So what AQ started doing at this point, that is preparing for worse, we started through the idea, through the leadership, we started planning to convert some of our facilities into areas which could help patients in case the pandemic gets worse. And these are the numbers of suspected patients, meaning who did not turn out COVID positive. And you see that we had a large number of suspected patients in March, which significantly came down in May, which means most of the patients who were admitted with suspected COVID actually did not turn COVID positive, whereas in June this number rise again with a fall. So we clearly saw that in the initial days in February and March, we had around 75% of patients with suspected COVID and 25% would confirm COVID. Now this ratio reversed in the May and June, where we had more of confirmed and less of suspected. And now we see again the reversal with a kind of 50-50 ratio of suspected and confirmed COVID. And these are some figures of the mortality rate, and the way the mortality has been calculated here is based on the definition of Agency of Health and Research. And you see that the mortality has kind of, it did peak in April, but it has kind of remained static from May to July. And these are the various length of stays that we've had from February to July. And you see that the length of stay was significantly higher of these COVID patients when we were keeping all patients inside the ward because we were not sending patients home until and unless they turn out to be COVID negative. And when we changed our practices in April, when we started sending COVID positive patients to home with oxygen, this gradually improved. Further, around April and May, there were introduction of drugs. There were more use of steroids. At the same point, tocilizumab and tocilizumab came first to be used as a trial drug. This further kind of decreased the length of stay. There has been a bit of fluctuation in June and July, but overall, the length of stay has significantly decreased across all equity levels. This is just a brief description. This is a very crude analysis. This is not the entire data of 1,000 people. This kind of description is based on approximately 700 patients. And you see here that the age group that has had most patients ranged from 51 to 60 years. And most of them were men. This is an extension of the same analysis that we did. It included 700 patients. And when we just kind of take a look at the major risk factors which have already been reported in literature, like diabetes, hypertension, ischemic heart disease, and chronic lung disease, what we found that mainly diabetes with the odds ratio of 1.9 and significant and very narrow confidence interval from 1.2 to 3.1, and people who had ischemic heart disease with an odds ratio of 5.3 and a relatively narrow confidence interval of 3.1 to 9. These were the two risk factors which increase the risk of having mortality if you had COVID-19. The hypertension was kind of borderline, and even people who had COPD or asthma, at least in our patient population, the risk was not very high. Now moving on to the second objective, briefly, just to tell you how the employees have done through. So in the nursing, we kind of had a peak in a slight peak in June. People who turned up COVID positive, and probably while we have followed strict PPE during this time, we had a lot of patients. And the other important factor here is that that was the same point in time that the community had a lot of COVID-19 infection, and a lot of nurses were also coming from the community. These are the numbers for doctors, and the same principle applies, that the disease was prevalent in community as well as there were a large number of patients in the hospital. And you can see the number of people who had to be quarantined. So it was quite challenging to run both COVID services, and also we had started seeing normal patients in June. And we had to undergo multiple structural changes to run the services. So, and this is a combined analysis of doctors and nurses. This is one a slide from my previous presentation where I had mainly focused on the challenges that are patient-related, structural, hospital needs, and staff-related. So I'm just going to kind of my next few slides are just going to be focused on the new things that we faced in this regard. So for example, one of the things that we initially struggled was when we had large number of suspected patients, and as you know that the suspected patient ideally should be kept in separate rooms. Then we had a large number of COVID patients, and we adjusted our ward environment according to that. And now again that the suspected numbers are increasing, what is becoming challenging, how to make structural changes to our wards to create more room again for suspected patients and less for COVID patients. So for other hospitals who probably will see the same change in the number and types of patients, they will have to think through this, that how they can change their ward facilities to quickly adapt to isolate suspected and confirmed COVID patients. Then I think the major treatment options that have come, I mean, in the past 2 months since I gave the last talk on this, there have been more wider use of steroid, remdesivir, which is an adenosine analog, came in, tocilizumab came in, and there are multiple studies that are currently going in AKU who are looking at the effects of these drugs. In fact, one of our colleagues in internal medicine, Dr. Zain Mushtaq, Dr. Bushra, and Dr. Syed Ehsan, they have actually published their data on the use of tocilizumab. They just wanted to see the therapeutic response of tocilizumab on COVID-19 patients, and they included those. It's a data of around 40 patients, and roughly what they highlight is that the outcome was improvement after tocilizumab was defined as improvement in oxygen replacement, and approximately 77.5% patients showed significant improvement in oxygen requirement. However, there was also a slightly higher chance of adverse effect like fungal infection. So they need much more close monitoring and infectious disease input. Also, another change that we saw in the last talk and a few months back, everybody was talking about that these patients should be intubated early. And now we have data that it was felt that current experience suggests that many patients may avoid complication of mechanical ventilation and possibly avoid clinical deterioration by use of non-invasive ventilatory support. So this is also a change in paradigm in the past 2-3 months, because based on the new literature that's coming in. And I must say that our unit of internal medicine, which houses the largest number of special care, has really done very well in maintaining these patients with non-invasive ventilation so far. Also, as we move on to see more regular patients, normal patients, and we have to understand that the facilities that were created for negative pressure, they have their limitations. So as we do presume that some number of COVID patients, which will kind of keep on coming even up to the whole of next year, although the number might significantly reduce. So we have to think of long-term negative pressure, at least limited rooms. And for this, the best solution that is reported in the literature are the HEPA filters, which are the high efficiency particulate arrestance filters. And however, they're very expensive. So it needs to be explored if locally made HEPA filters can be used in hospital for such things. Staff still is a challenge, and social distancing still needs to be emphasized. Although we have opened our eating areas with social distancing, but it is quite challenging to make the staff, remain separate. So this will need continuous emphasis, and so same goes for the personal protective equipment. Also another, you must have heard this in some other talks where online sessions have been introduced for undergraduate students. For the large number of postgraduate students, as internal medicine has one of the largest residency program at AKU, we of course face the challenge in sending them on rotations like cardiology and neurology. And while through the program director did arrange online sessions, just want to emphasize that the internal medicine residents were actually managing all the emergencies in the COVID unit, including acute ST elevation, MI, and stroke, and upper GI bleed, with the help of specialists. So this COVID has kind of been the old concept of internal medicine, the way we used to have in Jinnah Hospital or Civil Hospital, where there was a medicine ward in which all specialties patients used to be admitted. So I think this was my last slide, and this is a picture from our motivation session. Thank you.
Thank you so much, Dr. Aysha. We're going to take questions after the end of the next presentation.